go ahead and get started. We are recording today's call, and I know a lot of people will be kind of jumping in and out with us this evening or afternoon. And hopefully Dr. Ledbetter will be able to come here soon, and we will just pull him right into the flow as we get started. So first of all, I want to introduce myself. My name is Lee Ellington. I am the Executive Director for the Tennessee chapter of the Cystic Fibrosis Foundation, and I appreciate you all being here with us today, and we are so excited to be joined by several of our directors and care center staff from across the Middle, Southeast, and East Tennessee regions. If I could, I'd love to toss it to each of you just to introduce yourselves, the care center that you represent, and let everyone on the call today know who is joining us. So Dr. Brown, would you like to go first?
Sure. I'm Rebecca Brown. I am a pediatric pulmonologist and the CF Center Director at Vanderbilt Children's Hospital.
Dr. Callison?
Yeah, I'm Dr. Callison, and I am the Adult Program Director at UT Medical Center in Knoxville.
Dr. Toll?
James Toll, Adult Pulmonologist and the Adult Program Director at Vanderbilt.
And Stephanie?
Hey guys, this is Stephanie. I'm the CF Nurse Coordinator, Vanderbilt Children's.
We also have Dustin Tracy from my team on the line, our Associate Executive Director. If you're having any technical problems today or any issues with the Zoom information, feel free to direct chat him. He can try to help troubleshoot for you as we are going today. We are listening in webinar mode, so all attendees' cameras and microphones are off by function. But if you have questions as we're going, feel free to utilize the chat function, which is located most likely in the bottom left part of your screen. And we are going to obviously be covering today Trikafta's anniversary. Let me stop sharing our screen here. We put a poll out and we wanted to kind of know a little bit of who was attending today and your relationship to CF and to Trikafta. So directors, I want to let you know that we have a really good mix of attendees listening today. We have individuals with CF, and we have quite a few parents. We have a spouse with CF and some friends also. And the age range covers the gamut. We have individuals with CF under 2, ages 2 to 5. I don't think they're the ones listening, but you know, we've got some pretty powerful advocates out there listening on their behalf. Ages 12 to 18. And several in our 26 to 40 range. So lots of ranges of experience. 63% of our listeners are currently on Trikafta. So I'm sure they're particularly interested to hear what their experience is like compared to others. But we do also have several who are eligible, but not yet on Trikafta. I'm going to guess probably that younger demographic. So on this call, what we hope to be able to share with you all is really how Trikafta and the effects of Trikafta have been experienced across our region, what we're seeing on a more local level, as well as what our physicians have been able to pull from national trends. We want to be able to talk a little bit about that anticipated label expansion, as well as the future. What changes for treatment? How do things evolve here over time? So I've got several questions geared up and ready to send towards our panelists, but we're also going to have open Q&A time at the end of this call. So if there is something, that is really just ringing in your mind and we don't hit that topic, make sure to find that chat function here towards the end and be able to chat us in your questions, and I will grab those and we will throw them to our fantastic panel here. Again, we are hopeful that Dr. Ledbetter will be able to jump on, and if he can, we will work him in. And
he's in, Lee. He's an attendee. If you wouldn't mind switching him over.
I will move him. Thank you. Or Dr. Ledbetter. Promote to panelist. Okay. Good afternoon, Dr. Ledbetter. See your picture and camera, and how about your audio?
Yay.
Yay.
That was an adventure. I had the wrong code to begin with for some reason, the wrong ID.
It's a tricky system. I sent you guys several different links. So no worries, you're in and you're in the right spot and the right function. So fantastic. Thank you, everybody. All right, I'm going to toss the first question that I have actually out to everyone. So October 21st, 2019 was the day of Trikafta's approval. You know, we all have those kind of days in our history. You know, where were you when this happened? Where were you on 9/11? Where were you on these moments? For our CF community, Trikafta is one of those days. I would love to hear from each of you what that day was like for you.
I can go first.
So Dr. Brown, why don't you go first?
I was trying to get this adjusted and I didn't even hear what you said. I'm sorry. So whatever Dr. Brown says, I'll just add something to it.
All right, guys, we had a little kid interruption on my end. Dr. Brown, why don't you tell us first what October 21st, 2019 was like for you and hearing the news of Trikafta's approval?
So I think for me, I was at work when I got the news, and it came through a few different ways, through email and some alerts on my phone as well. And surprisingly through Facebook, shared by kind of non-medical Facebook friends, which was a little strange, saying, don't you work in CF? What does this mean? You know, that type of question. And I think for me, I felt kind of surprised that it was approved so soon, which was very, very nice. And then I think probably the next step was Stephanie and I sent texts to each other almost simultaneously saying, okay, now what? Let's figure this out. Does insurance cover it? How do we get this approved for our children? So that was my experience that day. It was very exciting. And then I think my next thought was, oh my goodness, the CF conference is coming to Nashville and this is going to be a lot of fun. So
right, we're going to throw a big party.
Absolutely.
Dr. Ledbetter, I know you've been in CF care for a really long time. What was that day like, that just monumental moment?
Oh, it was an amazing experience. I was a little surprised that they didn't wait until the conference and did one of the big plenary sessions. I would imagine the whole building would have collapsed. But we had our list of patients ready to go, and we actually started then. But, you know, I've been doing it a long time. And when I started, believe it or not, we didn't even know what the gene defect was. In fact, during my fellowship, the chloride channel was actually discovered. Because I started fellowship in 1980. It's been a long, I mean, so much has happened. And so it's like, finally, you know, all this work is going to pay off. So.
Dr. Toll, what was the adult side of things? Like, what was that experience?
So our experience, we had been a study site for VX659, which is very, very similar to Trikafta. It was the compound that went all the way through phase 3 studies, but was not chosen. But the effects were very similar. And so we had seen our patients who had been subjects in the study, we had seen these you know, huge benefits, and were kind of eagerly anticipating and kind of wondering when it would be approved. And there had been some sort of communication where Vertex had just reached out and said, was polling people on what their plan was. Would they be able to try to start people? And we just had a sense that it was coming, but kind of like Rebecca said, I didn't think it was going to be that early. I kind of thought they were going to time it right for CF conference. So once it happened, I think I was rounding or doing something up in the hospital, and my phone, our internal, you know, multidisciplinary team started texting back and forth, and there was lots of exclamation points and emojis, and then immediately, I think that day sort of set the record for patients contacting us. You know, everyone was excited and was calling in, so it was a very, very awesome day.
It's just the energy and the excitement. I know what our team was experiencing, the community at large, I can only imagine. Dr. Callison, what else would you add to the story?
I mean, really, just exactly what you guys have already said. I remember we had a couple of patients that were already on the clinical trials, and so we'd already seen the improvements that they had had, so we were just kind of counting down the days. It did come faster than I thought it would. I really thought it would come either at or right after conference. So we were all taken aback by how quickly they announced it. And then it becomes a scramble to, okay, we got to get everybody on drug. but especially those patients who are not already on therapies. I mean, just how exciting that was for our team, and to know that, I mean, that there were probably 15 people off the top of my head that I literally almost would think about on a daily basis. Hey, this person really is just waiting on drug, and to be able to notify them and to contact them and say, you know, hey, today's the day. Let's get you going. That was exciting.
Yeah, what a liberating experience, really, to be able to share that news. I can tell you from the CF Foundation side of things, we didn't know the day it was going to be approved either. And while being able to announce at conference would have been really fun, I think we're equally surprised that the FDA was like, oh, and now it is when it's going to announce. So we will take those really good surprises, though, any day of the week, whenever and as fast as they want to send them our way. So thank you for sharing. I know this was one of the questions I had asked Dr. Quintero. Dr. Quintero is our pediatric CF director at East Tennessee Children's Hospital, and she was, like Dr. Ledbetter, kind of thinking back to some of the early days of 2009 when Dr. Bob Bell, who was our former CEO of the foundation, came and made a comment in a presentation that one day there would be a pill for CF, a little blue and yellow pill that would help control essentially the progression of the disease. And she's like, we thought he was crazy. There was just, we couldn't wrap our heads around it. I thought there's just no possible way. And then flash forward 2012, Kalydeco was approved, and then now Trikafta, just what a marvelous milestone and advancement in care over the time that she's been in here as well. So really great. It was a great time to reflect back at how far we've come. And I think also a really wonderful opportunity to think about the vision for the future and what changes ahead of us. And I think those listening today are probably particularly interested in your takes on that space. So I wanted to, let's see, I have some numbers here to share with regards to sort of Trikafta's representation in the centers. And so give me just a second to pull this up. So everyone online with us can see today sort of what it meant for Trikafta to be approved. I'm going to share it in pretty view for you all, but we can see the table here. Across our Middle East and Southeast Tennessee, there's about 830-ish patients who are being seen by this collection of care centers, and 405 of those patients are currently on Trikafta. So we're looking at nearly half of our patient population on Trikafta. Pending the hopefully upcoming soon label expansion for 6 to 11, this is going to add another 113 patients within our region on Trikafta. So some really exciting numbers to see how truly expansive the effect of this drug is. And I wanted to ask Dr. Brown, maybe you can help us out with this, specifically on that 6 to 11 age category, who are maybe going to be the ones making that phone call on the day of approval, much like October 21 was in 2019. Could you maybe speak a little bit to what is the kind of more like administrative process and the steps for getting started on Trikafta? What is that looking like right now with COVID and other things in the mix?
Well, luckily, COVID doesn't make a lot of difference. The main thing would be getting people in so that we can get baseline lab work, get an eye exam if they haven't had an eye exam, like if they are not on another modulator, you have to have a baseline eye exam in order to get these prior authorizations to go through in pediatrics for the insurance companies. And what we find is usually the day that the medication is approved, none of the insurance companies have a process in place for prior authorization. It's not even on their formularies. So depending on the insurance company, that may take a little bit of time. Some insurance companies were very quick to approve and get it on the formulary. Other ones have delayed it in the past. And so I'm always surprised. I try to predict which ones are going to be our problematic insurance companies, and it seems. And so that's the main thing, is we get our list of patients, we start contacting people, we start setting up those appointments to get the baseline information. And then we move forward with the prior authorization process, which again may include building it from scratch.
It sounds like definitely a process, but I know one that people will be very willing to do their parts and to get information moving forward. So beyond the administrative side, I wanted to see if we could talk a little bit about what really the average patient's kind of physical experience is like when starting Trikafta. I think we hear a lot of stories, and it's something that a lot of our families are curious about. Dr. Callison, do you think, from an adult perspective, can you kind of share what you've seen across your care
Yeah,
center?
absolutely. So, I mean, so generally speaking, it's been milder than I remember, or it can be when that came out. People were having a lot of chest tightness, and we had several patients who had to stop because of that. Trikafta has really been a lot milder. That being said, really the description we hear from most of our patients is basically they didn't know they could make that much mucus during the first couple of weeks after starting it. And, and we do counsel them ahead of time, hey, especially for those people that have not been on modulators before, all of a sudden you're going to be normal again. So congratulations. Welcome to the club. You probably, if you don't have deodorant yet, you're probably going to go buy deodorant. Little things like that it's funny what people notice, but nonetheless, just how much mucus they're able to produce as they clear all that stuff out of their chest, whether they're sinuses, stuff like that. And, we usually tell them, hey, that first week or two, you may not feel as well. And that's generally been the case, and after the first week or so, they feel a lot better. But that being said, even while they're getting all that junk out, they still feel better. They have more energy. They are able to breathe better. So there is a little bit of that goes with it. But really, after that first week or so, many of them describe it kind of almost a euphoric feeling of feeling on top of the world because they suddenly can breathe again. Those people that are already on modulators, it's really not a huge difference. Although that being said, there is benefit above and beyond what's already there with the Symdeko and Kalydeco. So, not a huge difference, but they do feel better afterwards.
So you mentioned euphoric experience, and I think that was a really great word to describe some of the stories that we have heard. Dr. Toll and Dr. Ledbetter, I would love to hear from you. There's definitely a sense of Trikafta triumph. Some really, just fantastic turnarounds, really great stories of progress. Are there any that particularly stand out to you? Dr. Toll, I'll throw it your way first.
Sure, I feel like there are so many cases. And thinking about it, really, they're sort of different sorts of categories of experience. Probably the most traumatic to us are we had several patients who really were sort of in the transplant evaluation process, were sort of actively heading that way. Two or three stand out particularly whose transplant evaluations now are basically on pause or sort of have been told just come back. We'll see you back if you ever need to come back, which has been wonderful. Because I feel like really, those are the patients that when this first got approved that immediately came to our minds. But then so many patients who have commented on things like feeling like they have their lives back, really touching stories where patients have told us, I'm now finally able to sort of think about my future or think about seeing my children grow up or see my children graduating, personal goals. And it's just so many, it's almost, more than any one case that I could sort of highlight for months. It's almost sort of our clinics were so nice just to hear these stories of people's experiences.
Those are wonderful. Dr. Ledbetter, what about you?
Yeah, I would echo some of that in general, everybody feels so much better and is so excited. And I hear this, my life is back. And we actually still take care of some adults, although we are transitioning to an adult program soon. I have one adult patient that I've taken care of since he's 12, and he is almost 50 right now. And his numbers were really bad, and they didn't get any better, but he says, I can breathe, and I don't cough up anything. We can't even get a sputum sample. And he feels so good. He said, even if I was having side effects or my liver functions went up, I would still take it. You would have to make me stop. But I think the story that stands out most to me is that we've had a number of younger children that, between 6 and 11, that were really had significant disease. And out of the 14, we've been able to get 6 of them off-label use. Our pharmacist has worked really hard to get that done. And their improvement in their pulmonary functions and their BMI is just out the roof. And again, these were the bad ones, so you know, selection bias from how much they improve. But it's just a tremendous thing, and that just tells me that the sooner we can treat the younger patients, the more lung function we're going to save. But and even taking care of the older patients, the story with the younger patients to me probably stands out the most.
Absolutely.
Okay.
I know a lot of our families, upon waiting for Trikafta's approval, had heard of outstanding clinical trial results and had some anxiety. Will my experience be the same? You can find all of the miraculous stories that you want, which are incredible and just give you chills. But there's always just that little bit of concern, like, will that be my experience? Will it work for me? And so I wanted to ask, I know 2020 has been ridiculously difficult when it comes to collecting data for so many reasons. And it's going to be something that probably RCF investigators will forever have to asterisk and challenge against and say, okay, Trikafta did this to our numbers, but then COVID did that to our numbers. Where is what's in between? What does that really tell us about the first experience with Trikafta in our population? So we'll all give that caveat here, but I'm still going to ask. I would like to try and give a bit of a baseline expectation, an average expectation, to maybe help bring in line some of the really high stories and really low stories that people hear, to help give some baseline experience. So Dr. Callison, I know you had actually even mentioned a paper recently that was published. It was a 48-week follow-up. Could you maybe tell us a little bit about that?
Yeah, absolutely. So what they did was kind of the initial 24-week follow-up for kind of these studies. They basically continued to follow those same patients for now double the time, so up to 48 weeks. And what they found was that your lung function, FEV1, and BMI continued to stay, to have the same benefit. So we didn't see you didn't regress back down to where you started. So we know it continued to stay at least better, and some people even continue to improve past that 24 weeks. And so what that tells us is, hey, it works and it keeps working long after you start the drug. And I mean, that's kind of been the experience that I think we've all had in our centers, is that people do get better. That being said, we do have patients that their FEV1 doesn't really get a lot better, that may only get a couple of points higher. So it may not be that 10%, 15% that people are hoping to get. It may only be a point or two, but even those patients oftentimes are feeling a lot better. They're having fewer exacerbations. We have a patient who was, we have patients who get exacerbations all the time and all of a sudden are on this medicine. And I don't know the last time we gave them antibiotics, and so and I think from a COVID standpoint, the timing really was perfect, because there's no time like the present that you want to avoid being in the hospital if you can. And so our admissions have significantly gone down, but people's weight have gone up and they've stayed up, and their lung function's improved. And for those that haven't had the exact number improvement maybe that they were hoping for, generally speaking, they are feeling better and they are able to do more in their life. And so they've still seen benefit, even though the number may not be exactly what they anticipated ahead of time.
I saw a lot of head shaking from our other physicians as you were talking. So I get this feeling that that's a pretty good concurrence across the board. And Dr. Callison, I want to be mindful of the time. I know you
Yes.
We're going to have to jump off early with us. Any closing remarks?
Nope. I'm just glad. Thank you for doing this, and keep up the fight.
Thank you. Thank you. We appreciate you joining. We're going to continue with the questions with our remaining panelists here. Side effects. Side effects seems to be another topic of conversation. Dr. Brown, do you think you could maybe share, I know from an adverse side effect, I've heard about rashes, I've heard about headaches. What has sort of the experience been like among your care center? And is it what you expected?
Yes, so in the pediatric side, we haven't seen as much rash as a side effect. I think sometimes the adults experience that a little bit more, so I'd be interested to hear from the adult side. We've seen more problems with kind of GI upset. I think when you start to correct the defect in CF and correct that salt channel, sometimes the gut has to adjust. And so we've had some patients where we've had to actually go down on their enzyme dose. We've had other ones where we've had to change the reflux medicines a little bit just to help offset some of that GI upset. We have also had some of our patients who have had their liver tests go up a little bit. Luckily, we haven't had to stop Trikafta very often for that reason, but it is something we watch very closely with CF. And usually we are able to either go down on the dose of Trikafta and then slowly go back up again at a later date, and really work with our liver disease colleagues about how best to treat that and monitor that. Most of our patients have tolerated the medicine very, very well. We're actually hearing less reported side effects than we did with Orkambi and Symdeko. And so that's been very reassuring to me, that I think either they aren't having the side effects, our patients aren't having the side effects as much, or the benefits kind of outweigh talking about the side effects as much as they did with Orkambi and Symdeko.
Dr. Cole, from the adult side, are you experiencing the same with adult individuals with CF, or is it a little different?
I mean, I think it's fairly similar. Most people have tolerated it very well. The overall complication rate's been quite low. We haven't had to permanently stop it in anyone, and I think have only very temporarily held it in a really small number of patients for LFTs. We're learning a lot about the liver function test trends as this goes along, and we've noticed a lot of fluctuation that really may be just disease related, that we never checked before on a super routine basis before patients were on it. Rashes, definitely some patients get rashes. We've treated through every single patient with maybe one brief cessation. The interesting thing it's gotten some more press recently has been some of the sort of psychological side effects that may not be drug related or maybe more change in life related, but we've had some patients who have commented that they've just noticed a change in their mental health symptoms, some of which for reasons that where they're sort of told by their family and friends, you're so different now, and it just sort of makes them sort of affects the way they feel. And so we've had a few patients who, we consider that sort of an effect of the drug. But overall, tolerated very well.
It's really interesting, the mental side of things. I mean, goodness, this has been such a crazy year, but then to put a dramatic health change in the mix of it too, really, really layers on. Dr. Ledbetter, through the clinical trials, obviously they were testing for metrics on FEV1 benefits, BMI benefits, and exacerbations. Those tended to be the kind of big three. Have you noticed any other positive additional benefits with Trikafta, though, and other metrics across your patients?
Yeah, I'm sorry, I was getting my unmuted there, so repeat that.
I was asking, obviously, in the clinical trials, we mostly were looking at BMI improvement, FEV1s, and decrease in exacerbations. Those were the big three. But have there been any other positive benefits to Trikafta outside of those big three that you're kind of noticing among your patients?
Oh, I think that's easy. I mean, everybody feels better. Just as we've talked about, just the sense of well-being. And we've seen great improvement in FEV1 and in BMI, but even those who haven't improved, they just feel better. They have no cough. They have more energy, able to get out and do things that they had not been able to do. Yeah. So
I know people kind of wonder,
are my sinus issues?
I know some people kind of wonder, are my sinus issues going to continue to be as severe as they have? Or, what about my CF-related diabetes? Is that going to change anything? Any words of advice or direction on kind of maybe what you're seeing in some of those additional complications, if there's improved benefit in those spaces due to Trikafta?
You mean in the patients with CF-related diabetes? Not necessarily. I've not seen that. Some of the patients with their nutrition, we're having to cut back on some of their intake because they're gaining too much weight, and maybe changing some enzymes and doing all that. That, to me, that's one of the big things that we're having to do.
Mm-hmm. Dr. Brown or Dr. Toll, anything to add to the conversation around kind of adverse or pro good extra benefits or adjustments that you've seen
We've had a few
across?
patients whose glycemic control has gotten better. Definitely a few who especially who had milder CF-related diabetes and were not requiring a lot of basal insulin. Some of them have totally stopped. We've had a few who had more significant problems who have improved, and several have not, but it's definitely something where it has helped some.
Fantastic.
Haley, we've got some questions in the chat if you pertaining to this, if you want me to share.
You know what? I've got one more question on my list, and
Okay.
then I can kind of dig into the chat and start working through those. And it's one that I know I hear a lot of speculation on and have absolutely nothing to add to the conversation on what can be done. So I will toss it to our experts here, the one that is rolling around in most people's heads, and I'm sure you guys have answered a lot. But if you could, how do you expect Trikafta to change your approach to individual treatment plans over the long term? What does this really mean in the long term when it comes to that burden of treatment and all of the other medications? You know, what should families expect? Dr. Brown, can I ask you to answer first?
Sure. I think this is a question that's in a lot of our minds, and there are some studies looking at what we can peel away airway clearance wise for people who are on Trikafta. What I would anticipate is as Trikafta gets rolled to younger and younger age groups, there may either be a delay in starting all these airway clearance therapies. You know, right now the guidelines say we should be on all this airway clearance by 6 years of age. But if we're starting Trikafta at 6 years of age, we may not need to do that. And then there may be a delay in that, or we may not need to start airway clearance, except for in those who have bronchiectasis, the changes in the lung that happen from chronic infection and inflammation that we can see with cystic fibrosis. We know that our patients who don't have cystic fibrosis but have those changes in the lung often do need some form of airway clearance to help keep their lungs healthy. So in those who already have those changes in the lung, we may not get to a point where you can just completely stop all your airway clearance. But there may be some point in time where we have data to show us that we can, you know, tailor it down quite a bit and make life a little more livable, you know, decrease the burden of those treatments, which can take hours every single day when you're doing well. So that's kind of what I anticipate, but I think a lot of us are waiting to see what really happens as we learn more about the medication and the long-term effects, as well as some of these the studies looking at taking away hypertonic saline, for example, and, you know, do we do harm by doing that or not?
Right, absolutely. I know the foundation has a study going on right now for anyone who wants to look into it. It's called Simplify, and it's exactly what Dr. Brown was mentioning about removing hypertonic saline. And I remember hearing our medical team talk about how it is like the hardest study to try and design, because typically the whole model is maintain health, and then let's just see if something new will change it. But the concept of taking away something that has previously shown to help is much more scary. And so designing this in a way to be safe was a challenge, but they are doing it because they know it's needed. And they know that it's a space we have to look into. So Dr. Ledbetter, question to you. How do you think Trikafta is going to affect treatment over the long term? Or treatment
Well, I've
plan?
already mentioned, I mentioned one of the things about the nutrition, and we're following that very carefully. And we do actually have patients that are becoming overweight. And so we have to really watch that. And that's a good thing, you know. And as Dr. Brown said, you know, I'll just re-emphasize that. When I'm asked that, sometimes I'll tell people you transform from bronchiectasis with CF to non-CF bronchiectasis, which is a term that we use, you're still going to have to do your chest therapy. Now, what's the optimum chest therapy? Will we ever stop pulmozyme because mucus changes? I don't know. But right now, we're continuing to do everything. Occasionally, a patient will stop their inhaled antibiotics and the Pseudomonas comes back. So, we're telling people you've got to stay on all the things that you're on because the studies were done on their standard therapy. And hopefully, we can do something to decrease the treatment burden because it is, pretty large burden.
I mean, a slow and steady assessment. Dr. Toll, would you add anything else to the conversation?
I think for sure for all patients, a significant decrease in just the burden of treatments, like everyone has said. And really, I think, most likely, I'm starting to think, playing off what Dr. Ledbetter mentioned, thinking about a lot of the chronic problems that affect everyone, all patients that are related to aging and a lot of the things we have not spent as much time thinking about over the years. And I guess what I'm really excited and thinking about my existing adult patients, all those things are true, but kind of thinking down the road about patients who can start these modulators as young as is considered safe, and thinking about perhaps not even developing significant bronchiectasis, maybe even not developing a significant pancreatic insufficiency, and just thinking about how radically different those patients' lives will be.
Dr. Toll, you actually set up a really good segue for one of the first questions that I've been messaged about. You mentioned looking to the future, and to those who are listening, as you have questions, chat those in. We'll keep it going. We'll try to work in as many as we can here in the last 20 minutes of this call. So making future plans. I do think people are starting to look at their lives perhaps a little differently, maybe a little further out than they would. And in the adult world, a lot of that probably comes around to family planning and fertility. Can you maybe speak to how Trikafta has changed that conversation? Has it changed that conversation? Or have you noticed any kind of trends in that work?
Yeah, I'd say, it definitely has. I think sort of, interest in having children, or at least feeling like patients are capable of parenting and feeling better and feeling healthier has definitely increased that. Fertility for females seems to have increased quite a bit with Trikafta, probably for multiple reasons. Better nutrition, better overall health, just making the odds of being able to get pregnant higher, and obviously the effects on cervical mucus and everything affecting fertility. So it's already there where we've noticed that, and I think overall, yes, the net effect of both fertility and sort of desire to have children and have families is just going to increase.
It's really exciting.
It's very, very awesome.
Yeah, it's just incredible. It's the things that fuel us and keep us going. And, we're so excited for our community and just what this really means for them in the long haul. So it's great to kind of hear that playing out. Okay, I'm going to start going through these questions. Let me see. Dr. Ledbetter, let me ask you this. Due to COVID-19, our son was given a home spirometry device. Can you speak to maybe how accurate these home devices are versus what you use in the clinic? Oh, you're on mute.
Thank you. Yes, we've actually looked at that. People will bring their device in and do it in the office, and then we'll do a spirogram here. And they've been surprisingly close. So we're pleased with that. We still like to do ours in the office, but as a way to monitor at home, I think they've been quite beneficial.
Wonderful. That's really good news. I know that was a big project of the foundations when COVID went on or began to, that was a quick jump to try and get this distributed, and I think still in process. Couple shout outs here for some really great results on Trikafta from our attendees. And shout out to the Vanderbilt team, an update from the Margoshes family, so check that out. Here's a question. Let's see. I've had continual sinus issues, continual polyp growth, and multiple sinus surgeries, which included multiple years with no smell or taste. After Trikafta, it cleared and regained my taste. Not expected to have sinus surgery again. Dr. Brown, could you maybe tell us a little bit kind of about the sinus experience? Are you seeing, you know, does this sound like an experience that many in your center are also having?
Yes, so I've had several patients tell me that after that initial 2 weeks of just a whole bunch of sinus drainage after starting Trikafta, they've felt a lot better. Some have better sense of smell, have realized their taste has changed a little bit with that sense of smell coming back, and overall just feeling like they can breathe better through their nose. I think a lot of our CF patients don't realize how much their sinuses affect their sense of smell and everything else. So when it starts to come back, it's been kind of a shock for some of them, not realizing that they, for one, couldn't smell in the first place, and two, that certain smells actually smell different now that they can use their full nose and sinuses to the best of its ability. So yes, we've heard that quite a bit. We haven't had anybody who's gone to ENT and been told they won't have surgery again. Not yet, but that may come in the future.
I know, I remember hearing, I think it was actually on Kaleido's approval, but someone smelling bacon for the first time. And they were like, oh my gosh. And I just remember thinking, oh, that's so, bacon, yes, that's a like huge smell. Like that is fantastic. Well, welcome. Now you're going to crave bacon like the rest of us do. So, Dr. Brown, actually, I'm going to toss this next one to you. We know approval for 6 to 11. We've seen, you know, the trial results have come in, that's being submitted to the FDA, but that's in process. What about trials for ages 2 and up? 2 to 5 is that next group. Can you kind of tell our audience a little bit about what's happening there?
With COVID, I'm not sure how that's been affected. I know there was talk of doing those trials, and so you may have more updated information than I do potentially, but I think COVID kind of put a hold on some of that. We were very lucky that the 6 to 11 trials were already enrolled when the COVID mess happened, and so they were able to continue to gather the data they needed from that. But I think some of the other studies that were kind of in the pipeline after that have been delayed a little bit. But I know that it is in the works, so hopefully they'll be able to get up and running soon, or get back to running
I couldn't
soon.
speak specifically to it, but I can echo the general consensus among clinical trials that we have going on is that if it was fully enrolled before COVID, those have pretty well been able to move forward with little to no interruptions. Our challenges were in trials that weren't fully enrolled, and that process of getting a patient enrolled just really cannot be done virtually. And so those were essentially on hold for quite a while. Whereas those that were in process were able to kind of adjust and adapt to still get the data that they needed. So slight, but on that front, all of the labs that we are supporting are back up and working. All of the research, you know, things are opening back up as the country is opening back up. And so, you know, our investigators and our researchers were ready to move as soon as it's possible and are anxious to be pushing that forward too. So 2 to 5 will be the next age group, and then under 2, you know, would potentially be looked at after that, as we've seen kind of Kaleido or Orkambi and some of these other modulators follow suit. Another question, let's see. For those with one delta F508 mutation and one minimal function, has one minimal function mutation in particular responded any better than others? Have you seen any differences in, I guess, we'll call it secondary mutation. So not the F508 del, but in that secondary mutation, are you seeing a difference in the Trikafta experience for different patient populations? So Dr. Toll, can I put you on the spot for that one?
Yeah, I would say not that we've noticed, you know, the results that the 2 studies that were kind of done in parallel, the delta, 1 copy with minimal function and then 2 copies of delta F508, sort of the net result of all those ended up being about the same. Patients who had 2 copies were either on or put on Symdeko for a run-in period and then started Trikafta versus the patients who were never on any and then got put on Trikafta. And the kind of, when you add together the the two copies, it ended up being about the same. And I'd say that's our clinical experience as well. That the drugs really are targeted. The two correctors are targeted towards the Delta F508. So that's probably where they're working. And then the ivacaftor helps to keep the channels open. So I think ultimately we think the other mutation, at least for this drug, probably does not matter as much when you're talking about the minimal function. The patients who had a ivacaftor or glicoco responsive mutation were not in those studies. That's a separate study that they did. There was reference made during the CF conference last week. I didn't see the data presented, but someone said, sort of announced that they had seen potentially some additional benefit there. So that's still coming down the pipeline. But for the minimal function, I think it's pretty similar across the board.
So one last question. I was going to toss it to each of you, if that's okay, as we close here in our kind of final moments. So Trikafta is not the end of the advancements that are ahead of us. There is a lot more research that is happening in modulators, in genetics, in pathway cure, and meanwhile still looking to see how we can treat better infections. How can we fight, antibiotic resistant bacteria? There's a lot that's happening in CF research and care. NACFC, the North American Cystic Fibrosis Conference, which is geared for our care teams, was held last week virtually. So the question I wanted to kind of toss, with so much on the horizon, and yet coming off the heels of just such an incredible last year with Trikafta, what are you excited about for the future? What do we have to look forward to next? Dr. Ledbetter, would you like to answer first?
Off of mute now. I guess the Holy Grail would be able to have the gene correction at some point. That certainly never worked initially, and that's why we started off on the quest to find a corrector, a modulator. And so at some point, maybe that would be available. And I guess the other thing is finding, for all the other mutations, the few percentage patients who don't have a 508 or correctable mutation, finding something for them. So it's not over. Certainly the fight is not over. And we have a number of patients with two, mutations that there's not a modulator for. So got to keep looking.
We're going to keep looking for sure. Dr. Brown, any research in particular that you're following and really interested in?
I think at last week's conference, the stuff that has me excited is exactly what Dr. Ledbetter was just talking about, the gene editing or some of that other research, which maybe will give us an option for treatment for those patients who are not eligible for the modulators that are out there right now. Because I think while we've had such big success with Trikafta, it's important for us to keep in mind that there are some people for whom those medications don't work. And from my patients, what I hear is that they are really excited to see all this improvement, but they wish some of it was directed their direction. And so I think making sure that we continue to work to figure out treatments for those patients as well. And especially since that gets into some of our more rare mutations, that may take some time and may take some special research techniques that I do not understand at all, but I'm happy to hear about at these conferences. I think it'll be important for us all to continue to support that work and make sure that we continue to enroll people in studies so that we can keep that work going.
Dr. Toll, what are you looking forward to?
Well, I definitely will echo the others. The one downside that this last year has exposed is just that there are still patients who have not been able to share in all this joy. And so what I took back from last week's conference was being very excited to see how many different types of techniques were being studied and were sort of coming down the pipeline. And a couple of them hopefully we'll be able to participate in some of those studies. But just thinking about being able to really be able to give these benefits to everybody, definitely what I'm looking forward to the most.
Yeah. I think that's one of the most special things about the CF community is it's a community, it's a family. And, you know, it's not just our families who are affected by CF, but it's our care team, it's the organization, it's our friends and family who are really, truly 100% committed to every single person experiencing these benefits. And I just don't know if you find another group out there like ours, being able to be in our volunteer conferences, be at the medical conference, you just, that energy and that synergy that exists with everyone focused on one goal, it really is something special to behold. And so, you know, I thank you guys for being a part of that, for pushing for the progress, for all the care that you provide for our CF families. I will plug the NACFC plenaries, a lot of which they just spoke to. There are 3 plenaries which were streamed on Facebook Live last week and are still there and viewable on the Foundation's page. So if you're curious to hear a little bit more about some of the things that our physicians have teased you about in progress, there is those recordings available out there right now. You can go check that out. And, you know, I just want to say thank you. Thank you for your time today. Thank you, physicians. I know it's very difficult between clinic visits to jump on, but I do think virtual has given us a few more opportunities, and I really appreciate you all joining with this call and the series of town hall calls we've done this year. Attendees, thank you for your time as well and for joining. Thank you for your questions. Thank you for participating. If there was anything that didn't get answered today that you want to know more about, reach out to your care centers, have that conversation. If there was something maybe in a more personal nature, you know, those conversations are welcome. Please have those. If you're more interested in foundation work or research or clinical trial, organization structure, we're always here at the chapter available as well. And again, I thank you all for joining, and we will sign off. Have a wonderful rest of your day.